Good afternoon, everyone, and welcome to our Learn and Share conference call. I'm Russ Derry. I'm the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is the nature of epilepsy from causes to consequences, and we're very pleased to have with us as our speaker Dr. John Bunka, who's an epileptologist with the Bronson Neuroscience Center in Kalamazoo. So, Dr. Bunka, can you briefly share your clinical and research interests and kind of describe your experience with this topic?
Sure. So, my interest right now is in epilepsy and taking care of those patients who suffer from epilepsy or non-epileptic seizures for that matter. I really like to take care of all patients and deal with all different kinds of things regarding epilepsy. In terms of my research that I've done, in training, I focused a lot on non-epileptic seizures in addition to things that, the variations of how medication can impact people with epilepsy and producing seizures. But at this point right now at Bronson, we're not actively pursuing any research models at this time. But my interest is basically in general epilepsy and also non-epileptic seizures.
Great.
And I should tell you a little bit about my background. So my background is I did training at Michigan State University for neurology, and then I did my epilepsy fellowship at U of M.
Excellent. Okay. So epilepsy is not a single condition, but the general term for a wide range of conditions associated with recurrent unprovoked seizures. And the substantial variation that we see in the symptoms of epilepsy can be attributed to the many different genetic, structural, metabolic, and environmental factors that can contribute to development of epilepsy. It's also influenced by the many different parts of the brain that can be affected. So on this call, we'll discuss how the cause of one's epilepsy and the parts of the brain involved can affect that person's diagnosis, treatment options, and prognosis. So can you start by describing what we currently know about epileptogenesis, which is essentially the underlying process associated with the development of epilepsy?
Yeah, so I think that's a pretty interesting term, and I think it is one that I don't think is commonly used, at least not in the clinical setting. So I think patients probably haven't heard much about it before. But kind of briefly, like you mentioned, it is the process for which our neuronal network kind of reorganizes and then kind of puts us at risk or puts a patient at risk for having spontaneous or chronic seizures. And for a long time, although neurology is a relatively new topic in terms of medicine, it's been looked at for over many years, hundreds of years, and we have evidence even dating back to 100 years ago or so where people understood that seizures in and of themselves sometimes produce seizures, and we've been kind of working from that standpoint moving forward for a long time about trying to figure out what causes them. Although we made a lot of really good research into figuring out what it is that produces seizures, this is still a relatively new topic with a lot of debate kind of intermixed within it. But I think it's important for us to first understand what that term means, but then to kind of figure out where to go from there. And so I think across the board, we understand that there are basically three phases that deal with epilepsy and the production of seizures. And those three phases are broken into something called, which we use the term as the initial insults, and then there's a latent period and a chronic epilepsy phase. And throughout most of this time, we believe that there is evolution in which the cells change that help us produce the risk for having seizures. And we'll kind of talk individually about each of these different phases. So the first phase is that initial insult phase, or the precipitating event. And you might consider, I think overtly a good precipitating event would be perhaps a stroke or a traumatic brain injury, but a lot of changes can happen even in intra-utero, in which may produce a chance for someone to develop epilepsy. And then it's within this initiating event that time evolves, and over time, the evolution of time during this latent period, the risk of developing epilepsy is develops. And so that period of time can sometimes be, days, even up to over 10, 20 years. And we see that within traumatic brain injury. And then, the second stage, or the last stage, I guess I should say, is the chronic stage. The chronic stage is what we define as those who have now developed epilepsy and are on epilepsy medications or need to be on epilepsy medications. And there's debate that and I agree with this topic, that there is still further development even in the chronic stage of someone who has epilepsy, which may produce a further risk for them into having seizures. And then, we believe that the chronic phase is a provocative aspect of seizures because we see changes over time within the brain as people who we see, as we're seeing them. Those changes can be included in, like, the hippocampus. We see that there's asymmetry within the hippocampus over time, or there could be atrophy of the brain over time to kind of show us that there is still further evolution of someone's epilepsy past the development of epilepsy. Now, in terms of what we know about the evolution of seizures and what happens to the cellular structure to the brain during this latent phase, that's a little bit more challenging. We do know that there are changes. There are cells within the brain which are called microglial cells, which are kind of like cell structures which kind of eat up bad brain tissue or tissue that's not supposed to be there. We know that there's sometimes overactivation of these particular cells in an area where there's epilepsy. We also know that there is breakdown of other cell structures within the brain called astrocytes, which help us produce a good balance of ions and nutrients within the cells and help us produce signals that transmit down the cell structures too. I mean, we see inflammatory markers that kind of happen as well. And then we're also seeing, like, the loss of neurons too, which can help produce seizures. Now, in terms of what happens if we break that down even further and look at the different channels that help us produce signals in the brain, we see that there's changes even at this structure, at this level as well, that also support that there is a further evolution to produce seizures. And I think what's important to know, though, is that when we're looking at epileptogenesis and trying to figure out what happens to the brain, we're using models to help us understand that. And a lot of the models are based on mice models. And there's a lot of debate within the neurology world of whether or not these are completely applicable to patients or not. When we're looking at how the human tissue evolves to produce seizures, it's challenging for us because not every insult that happens to a brain will produce a seizure. In fact, we don't know, what may make a certain insult in one part of the brain cause someone to have a seizure or not. We're not sure of that. And so we don't investigate every injury, and then we don't see the changes over time until someone develops epilepsy, and then they're brought to our attention. So there's that latent period for which a patient is asymptomatic. We don't have a lot of data about how the brain tissue looks during that time because we just aren't really aware of the patient until they're brought to our attention once they have seizures.
Right, that makes sense. All right. Well, have researchers made any progress in developing interventions to either prevent, halt, or slow the process of epileptogenesis in those who are at risk?
Yeah, unfortunately, I think the short answer to that is that we have not yet really developed medication or an idea of what to do for that. And again, a lot of that comes back to the idea that we still don't have a clear idea as to what really makes a seizure or makes an insult progress into someone who has seizures. But there is some data that we've begun to look at that has shown that potentially if we can somehow skew that latent phase, so during that phase when there's an initial insult, if we can somehow improve that phase, that maybe we might be able to halt seizure progression. So if there's a way that we could potentially halt inflammatory markers or inflammation from happening, that maybe we might be able to prevent further breakdown within the tissue that might produce a seizure. And one a scenario that this could be kind of translated to is someone who might suffer from, or who could potentially suffer from juvenile myoclonic epilepsy. And there is some of the genetic factors that contribute to this disease do in fact occur when there's abnormal tissue which is being made hyperexcitable or by having too many of certain neurons within an area. And if we could somehow figure out how to specifically target that genetic mutation, perhaps we could stop seizures in that way. And that is, I think, a big thing for what neurology and epileptology is looking into, is how to use genetic data to figure out if someone's at risk for developing epilepsy, and then also maybe there might be a way to kind of further prevent seizures moving forward. I guess one way, that we could consider stopping seizure progression is to having further, maybe being a little bit more aggressive in terms of when to treat a patient. So again, like over 100 years ago, we understood that when someone has a seizure, that their risk of having additional seizures moving forward is higher. And then there was a term coined, which is that seizures begot seizures. So if we can somehow stop a patient from having more seizures, perhaps we could stop that progression from, within the chronic phase, somehow reducing the amount of seizures that someone has.
Right. Yeah, that makes sense. Okay, so can you describe the 6 main ways to classify the cause or etiology of epilepsy, and kind of the rough percentage of people with epilepsy within each of those categories? And the categories specifically that I'm referring to are structural, genetic, infectious, metabolic, immune, and unknown. So if you could talk about each of those and kind of where a little bit of the epidemiology of that in terms of where people fall.
Sure. Yeah, so these terms were kind of coined in 2017 by the International League Against Epilepsy, and they help us because they help us kind of categorize a patient as to why they might have epilepsy, which I think has been really helpful for us. So the first category to bring up is structural changes that produce epilepsy, and so this is commonly why we'll order an MRI when we're trying to identify someone who may suffer from seizures or may suffer from epilepsy. And what we're looking for is distinctive abnormalities within the brain which have shown a risk for developing epilepsy. And these things can include things like cortical malformations or vascular malformations, but they can also include things like stroke, traumatic brain injuries, traumas, and hippocampal asymmetry or hippocampal sclerosis. And if we're looking at some of the areas that we can identify the percentages of which, so we can see that about 6% of all people with traumatic brain injuries will develop epilepsy. About 11% of people who have a stroke will have epilepsy, and then about 7% of epilepsy patients will have hippocampal asymmetry or sclerosis, and then 6% of those will have trauma. So that's that one. And then we also have people who have infection. So infection is probably seen in about 4 to 15% of those who have epilepsy as being a central cause to their epilepsy. And this can be defined both as a term called acute symptomatic seizures or remote symptomatic seizures. And we define those separately and differently because there are different risks associated with each of those types of epilepsy. So acute symptomatic seizures are those seizures which occur within 7 days of an acute event, and the event in this case would be an infection, or there can be changes which are a result of the infection, which cause a patient to have seizures, and that would be a remote symptomatic. Some of the causes that are the most common are things like tuberculosis, HIV, neurocysticercosis, which is it's a parasite infection which then comes from the gut, and then it develops into the brain, and we see that there's inflammation, and this inflammation will cause seizures. The next category is an autoimmune cause, and this is kind of a newer definition that we're beginning to realize is something that's pretty important. This is pretty rare. This is about in 1% or so of patients that will see this. But this is a seizure type for which occurs as a result of an immune-mediated response that produces seizures. And I think we'll talk later on this more in detail.
Sure. Yeah.
And then the genetic causes are also common. Those are about in 15 to 20% of patients with epilepsy. And this is defined not just as an inheritable reason for developing epilepsy, but also from de novo, meaning that it is produced within the patient's body during development, and they have a genetic abnormality as a result of that. And so this would be something like, juvenile myoclonic epilepsy, but it could also be a metabolic problem, too, that develops later on. And that kind of brings up metabolic causes, which are also rare, and those are things where there's abnormalities which are occur because of abnormality within the body. So something that like some sort of glucose deficiency or something to that extent, which might cause epilepsy. And then I think the other one was unknown, and that is a rapidly changing percentage, but somewhere around like 60% or so that we're not really sure as to what causes their epilepsy. But over time, we're beginning to realize that a lot of those things which we defined previously as unknown are now becoming things like genetic causes of epilepsy that we're finding out over time.
Okay, great. Well, that's a great overview, and we'll dive in a little deeper to some of those categories as well. Looking at these categories, what statistics do we have regarding prognosis? Or not necessarily statistics, but just what do we know? Are there certain etiologies that tend to have a worse prognosis and others that tend to have better prognosis?
Sure. So it's very it's challenging to give you just based on the specific categories which are best, but within each of the different categories there are certainly epilepsies which have a better prognosis. So one might say patients with like absence epilepsy, so then that genetic epilepsy, that their risk of becoming seizure free is quite high, and their prognosis would be quite good. In one Denmark study recently, they published some data that describes that those with primary generalized epilepsy, about half of the time, these seizures will remit over time. And they also showed that about 30% or so of seizures, which are complex partial seizures, will remit over time. And I think what's the most important thing to know is that epilepsy across the board has a very good prognosis, where most of our patients, about 60 to 70% of them, will respond really quite well to medications alone. And I think that's probably the most important part for us to consider that. But once we have a patient who's on medication, we know that there are risk factors which might predict them for not being withdrawn from medication. And those risk factors are things like if they've had a lot of seizures in their past, if they're on many different medication types, if their duration of treatment is long. Those kind of things seem to show us that there is maybe a poor prognosis. But I think across the board, you have about a half a chance or so of where the seizures will likely remit. And even in patients who have catastrophic epilepsy in childhood, about less than 30% of those will have a remission of their epilepsies. So it's a pretty wide range of how someone might respond, and it's kind of individualized, I think, based on the type of epilepsy that someone has, and then also the different types of treatment that are available. And that I think we can talk to later on as well.
Sure, right. And if you look at within any of those categories, there's a lot of diversity within those categories, like genetic, childhood absence is one type of genetic epilepsy, and then on the opposite end of the spectrum, you have something like Dravet syndrome, which has very much worse prognosis. So there's a lot of variation within each of these categories. So, so for those with epilepsy or those whose epilepsy cause is classified as unknown, what are some of the most likely explanations for why they developed epilepsy? Again, obviously it's unknown, but what's usually suspected in those cases, or what are some possibilities?
Yeah, so I think there are two things which when I see an epilepsy and I don't know why it's occurred, I think there are two things that I'm commonly thinking about, and I think one of the most common things I think is that we just have a lesion that hasn't yet been defined or that we can't actually see. So although our MRI technique has improved greatly, we still have a lot, I think, of improvement to do, and there's still a lot of detail that we can't see. And over time, we've begun to develop different techniques utilizing the current MRI technology that we have, which have allowed us to kind of better identify abnormalities, like something like cortical dysplasia, which you may not be able to see on standard MRI, has different types of ways of utilizing MRI in the research model for which it's beginning to look like we can see it better. So I think a lesion which hasn't been defined for focal epilepsy is something I certainly think about. And I think probably the standard response to this would be that a lot of us think that genetics is probably where most of these patients will eventually fall into. And we would believe that because over time, even there's just been an explosion of research into how genes are playing a role in epilepsy, and we previously just did not have the technology or really the understanding of how this happens. And as our ability to test more and more patients has come to fruition, we're able to do more tests on patients and see that there are in fact genes which are contributing to epilepsy.
Right. So clearly advances in genetic testing are going to help move some people from that unknown category into the genetic category. Some of these advances in MRI techniques and approaches will move some more people to that structural category from the unknown category. What about like metabolic, infectious, and immune? Are there any additional diagnostic tests on the horizon that may assist with identifying more cases of those?
So in terms of autoimmune, I think that's kind of also very rapidly exploding in terms of what types of impairments might cause different types of seizures. Again, it's still a quite rare form of epilepsy, but we know based on clinical responses, like with someone who might have epilepsy, that they're responsive to steroids or other immunosuppressive types of medication and their seizures respond. We may do further testing which doesn't show evidence, and that doesn't mean that there isn't an autoimmune process that's taking place. Just means that we haven't yet identified that. So I think this is something that over time we're really going to see a lot of data come by and a lot of information that will show us that there is an autoimmune process that's taking place. I don't think that autoimmune is probably as high of a prevalence as maybe some of the genetics are, but I think that it is something that we will be seeing expanding in the future. And the reason why it's so low is because it's really a relatively new concept for us to understand that autoimmune processes outside of someone having an overt tumor may be contributing to seizures. In terms of the metabolic changes, I think that's also something that we're probably learning more about too. This is something that is most commonly seen probably in the pediatric population, but I think that's also going to help us. I think with more research we'll see that there is an expansion of this category as well. And then with infection, we are developing more techniques to help us understand that, help us better detect infections that are taking place now or maybe had taken place in the distant past, which may be contributing to someone's epilepsy. But really it's just a matter of us getting the ability to test patients. And what probably prevented it from us from looking in the past was more just a cost that was limiting it. But as technology has increased, so the cost that's attributed to investigating these types of pathologies has decreased, and it's allowed more research, I think, to occur and allowing us to understand there are these changes that are happening.
Right. Okay, so we're going to go into a little more depth about genetic epilepsies. So among genetic epilepsies, can you explain the distinction between inherited or germline mutations versus acquired or somatic mutations? And you kind of referenced this earlier, but can you just kind of review that again?
Sure. So somatic mutations or acquired mutations are mutations which happen once the cells have already begun to form. and then that mutation is passed down from the progeny of the cells moving forward, and it's not present within the germ cell line. So that means that it's not passed from a dad or a mom to a child, but it happens within the cells that are already being developed, and then from that cell moving forward, the cell structures are abnormal. So an example of this might be a mutation with mTOR, which helps in the development or the destruction of tissue as it goes on, and we see that this occurs in about 15 to 20% of people with cortical dysplasia, and cortical dysplasia is known to cause seizures. Now, in terms of inherited or germline mutations, this is a mutation which is passed down from a parent to a child, and there are many different types of epilepsy which are categorized within this line, and I can list a few, and I plan on talking about a few of these and moving forward, but some of those are abnormalities like autosomal dominant nocturnal frontal lobe epilepsy, which has a mutation in the CHRNA1 gene. We mentioned a little bit about the Dravet syndrome or genetic epilepsy with febrile seizures plus syndrome. And then that is a mutation with SNC1A, and the juvenile myoclonic epilepsy we monitored, and there's other types of myoclonic epilepsies too, which show that there are gene abnormalities which cause seizures.
Okay, great. So can you give us an example of a genetic epilepsy and kind of break down how the mutation ultimately leads to the symptoms experienced and the treatments used for that type of epilepsy?
Sure. So, I mentioned juvenile myoclonic epilepsy, and one of the genes that's abnormal, and there are many different genes which are abnormal within a patient who might have JME. And again, it's important to know that not every patient who has JME has these mutations too. That's part of the problem with genetics, is that not everyone exhibits the same, and sometimes they'll exhibit different symptoms too. But the one gene that I'm referring to now is called the GABA-1 gene, and this gene is responsible for the development of one of the pieces to the GABA receptor protein, which is an inhibitory channel within the cells that kind of helps us control the different charges within the cells and the different types of signaling that happens. What happens is that after infancy, the influx of chloride ions creates an environment in the cell that inhibits signaling between the nerve cells and then prevents the brain from being overloaded with too many signals. And when you have an abnormality within this gene, you lose that ability to inhibit the abnormal signals that shouldn't be there. And as a result of the signals not being controlled, there's an overstimulation of the neurons. And again, we're not certain of this, but researchers have believed that this overstimulation of neurons may trigger the brain to then produce a seizure or give it the chances of a seizure to occur. Now, in terms of specifically treating a patient with a certain type of medication as a result of this genetic gene, we don't commonly do that right now for this type of epilepsy. Although perhaps you might take a medication away that works on the GABA channel, but for the most part, the genes of this type of epilepsy do not coordinate what medication we try. I think what helps us understand what medication to try with this would be just based on clinical experience and from what we've accounted for. Now, I do believe that over time this is going to change, and I think over time, once we understand what genes are playing a role in what type of epilepsy a patient may have, I think that we're going to start using medications based on genes, and this is something that I think probably will happen within the next 30 years or so. But at our current rate, we don't do that. Now, that being said, we mentioned Dravet syndrome as well, and there's problems within the sodium channel with this one, and that might lead us to try to use medication which does not act upon the sodium channel. So we do use the genes in some ways, but it's not really the driving force between what we do and we don't do for genetic epilepsy.
Sure. Okay. Can you describe some of the most common structural changes that you see as causes of epilepsy? And for each one of those, talk a little bit about how these changes are likely to influence symptoms, prognosis, and treatment options.
Sure. So we mentioned lesional epilepsy, and we mentioned that a common one is a vascular malformation. And I think one of the ways that we would change the way that we're treating a patient based upon this would be that if we define that a patient has epilepsy and that their seizures are occurring around the angioma, for instance, we may advocate for the patient to have resection of the angioma and the surrounding tissue around that, whether it's hemocyte deposits or inflammation. And if we remove that tissue, there is evidence that having resective surgery with those has a very good chance of having seizure reduction, something around 70%. So when we see a patient, when we can visualize that there is an abnormality within the vascular, vascular malformation or something like that, we would be advised, to chase that down and to treat that, as opposed to just, trying one medication after another. We may just say, let's do surgery. Another example of this would be someone who has mesial temporal sclerosis. And if we define that on MRI and again confirm that their seizures are coming from that temporal lobe after having tried a single medication, and if they were to fail that medication, we'd be much quicker to promote them to receiving surgical resection because the likelihood of them becoming seizure-free with surgery would be in the percentage of the 70% or so, whereas if we were to add another medication to that, the likelihood of having seizure freedom would be much lower than that with medication alone.
Right. And with temporal lobe epilepsy and mesial temporal sclerosis, there's also as we talked about earlier, about the epileptogenesis and the fact that during the epilepsy that process continues. Does surgery kind of address that progressive nature of temporal lobe epilepsy?
Yeah, so that's a good question. So I think that it probably does. This is probably more just opinion than it is fact at this point, but I do think that it does. I think if we use an understanding that seizures will produce more seizures, the longer that we wait, perhaps the more likely there is going to be evolution of a patient's epilepsy. And so if we wait, so there is some data behind surgical resections, and about 30% of those who who have mesial temporal sclerosis will not have reduction of their seizures or resolution of it. And if you look at some of the data, or at least case series from different surgical sites, they kind of comment that there's somewhere around 1 to probably 5% or so of their patients who are found to have a separate location of their seizures after they have had a resection, and you could hypothesize that perhaps that was part of the process that occurred with that patient population.
Interesting. Okay. Sorry, did you have other structural changes that you were going to address, or I didn't want to?
No, I think those are probably the most common. I think the mesial temporal, and then yeah.
Okay, great. And actually, you mentioned cortical dysplasia. That would fall under structural, right?
Yes, yeah, and so
what do we know about that in terms of treatment? Or how that affects treatment or prognosis? I guess it's a fairly common cause of epilepsy. So what do we know about that? I guess.
Yeah, so we know that surgery is a great option for them for the most part. There are two different types. One of them, which is more, and this is why we think that we may not be able to see all of. So when we're doing that imaging, we may not be able to identify all the different types of cortical dysplasia, because sometimes the cortical dysplasia is so diffuse that there really isn't a visualized difference when we're looking at it. And so there are different types, and they respond separately to surgery or not surgery. So cortical dysplasia type 1, that does seem to respond to surgery because there is a focal change that we see. Whereas cortical dysplasia type 2, where we're not able to see the changes in MRI, that may be a little bit more challenging for us to resect them. what we find is that on people who we do surgical resection on, where we have a non-lesional or a non-lesion, when we look at it under microscopy, a lot of times we do see that there is cortical dysplasia within that product for which we resected. And so I think that a lot of what, I guess I probably should have mentioned that earlier, but a lot of like people who have focal seizures that really can't identify why they might have it, they would likely fit within that. That's another thing that I think about, is that they're fitting within that category of focal seizures from cortical dysplasia for which we are not able to visualize.
Right, great. Okay, can you briefly talk about autoimmune epilepsy? And again, we've discussed this a little bit, but anything about suspected mechanism by which this causes seizures, how to diagnose it, those types of things.
Sure. So this is a relatively new and relatively rare form of epilepsies that we have so far. And how we define it, again, it's important, is that it's an epilepsy which is based on a category of neuronal cell antibody surface antigens, which are shown to cause epilepsy. And this is also very rapidly expanding for us. Probably two of the more common types are voltage-gated potassium channels, or NMDA, which is I think you hear a lot about those in the news and stuff. What those do is that they work on the channels themselves within the cells, which impair the way that the signal is working or moving, and then as a result of that impairment, for which they then have seizures. So the signal is being changed, and they then have seizures. This commonly impacts like the mesial and the limbic structures, and the way that we try to analyze this or try to assess whether or not a patient has risk or not is to do a lumbar puncture, but also do blood work, which helps us test for the different antibodies which are formed either within the central nervous system, or like the CSF, or within the body, the blood as well.
Okay. So you mentioned...
I didn't mention treatment options for that. Sorry, you had asked for that.
Yeah, go
So
ahead.
the treatment options for that are commonly to use things like autoimmune suppression. So we usually consider using like steroids within a hospital admission, or we'll use IVIG or plasmapheresis, which kind of pulls out the antibodies in the system. So we're really trying to remove those abnormal antibodies. Sometimes, like with an NMDA, we'll find that there is like a tumor that's developed that is causing the patient to have these symptoms, causing these antibodies to occur. And so the common thought is to look for a tumor as well, and if a tumor is found, to remove that. And the thought behind that is that if we remove the tumor, that the antibodies that the body is making to kind of fight that tumor will also go away.
Okay, and just in general, for someone who has drug-resistant epilepsy, who nothing has worked for them, is it a good idea for someone who's basically tried everything, who doesn't have an identified cause for their epilepsy, to ask their neurologist about some autoimmune epilepsy and the possibility of that, because it's still relatively new?
Yeah. So I think that's one of the things that I usually will think of to try when someone who has really refractory epilepsy and hasn't really responded to medication is to consider a trial of something like that. A lot of times, what we'll see with autoimmune epilepsy, because it affects like the limbic and the mesial structures, we'll see mood change, we'll see cognitive decline. And so we look for a lot of other symptoms which will suggest that as a potential risk for them to have this type of epilepsy. But it is certainly something that I think should probably be discussed if it hasn't been discussed with a patient, just so that a patient is aware that we're thinking about this, and you either do or you don't fit that criteria. And again, sometimes we'll find that when a CSF study or a serum study is done, we won't see the changes that we're looking for, and it doesn't mean that they don't have autoimmune epilepsy. It just means that we haven't yet defined it. And so what we're looking for a response or improvement with these immunosuppressing agents.
Okay, great. Just in the interest of time, I think we're going to skip over infectious and metabolic epilepsies because those are a little less common, but there are some cases where an epilepsy can have causes that fall under more than one of these categories. Can you give a few examples of those?
Yeah, so when you think about these, there are quite a few that you could think of where this is the case, and I know some of the ones that you were thinking about were like someone who has tuberous sclerosis, so that will be a genetic malformation with the TSC1 or TSC2 gene mutation, but as a result of this gene, that tubers are formed, and once tubers are formed, the tubers then make a patient at risk for having seizures and then developing epilepsy. Commonly, infections will also do that. So a common one we mentioned before where like cysticercosis can cause, that's the acute infection, but then later on that'll cause calcium deposits, and these calcium deposits then help make a site maybe more inflamed or irritated, and that irritation then makes development of epilepsy. We see this commonly also in herpes infections, which infect the temporal lobe, and so when you have an acute herpes infection, and then the temporal lobe is impacted, you now have a infectious etiology, which then leads to a structural etiology of having had epilepsy. And then, yeah, as you said, there are many metabolic issues that can cause, which are genetic as well as metabolic, which will cause someone to have epilepsy, like glucose transport 1 deficiency or something to that extent.
Right. Okay. So now I'd kind of like to take some time to go on a brief tour of the brain and talk about how the location of the seizure focus influences symptoms, prognosis, and treatment options. Can you talk about this for some of the most common areas of the brain that are affected in epilepsy?
Yeah, so I kind of jumped the gun earlier to talking about the temporal lobe epilepsy, about how when someone is found to have temporal lobe epilepsy, that it's a very common form of epilepsy. And then what will allow us to then advocate for treatment or not treatment would kind of lead us to where it's located. So let's say if someone were to have a non-dominant hemisphere temporal lobe epilepsy, this would allow us to then say they might be a very good candidate for having a surgical resection as opposed to us trying to add additional medications. If their epilepsy occurs on the dominant hemisphere, so it's the side that their language is mostly found on, then that might lead us to saying maybe resective surgery isn't the right option for them. So maybe we might then lead to trying additional medications, being on a second or even a third agent. And then if it's still refractory, would we consider doing a form of surgery like VNS placement or responsive neurostimulator placement would also be an option for someone like that. So you mentioned multifocal epilepsy, and that is that's a very challenging form of epilepsy. And we define multifocal as having had 3 non-contiguous areas of abnormalities, which we find on the EEG. And those could put a person at risk for both focal seizures or also generalized seizures. And there is some evidence or some thought that you could do peel resection, so you can take off little chunks of the brain for which you think that the different foci are occurring from. That probably is, I think, a debated topic of whether or not that's something that should or shouldn't be done. Some centers do not do that because we're not certain of that, whereas other ones will do that and have found good benefit with that. So that is, I guess, more center dependent. But for the most part, I would say that with someone like that, medication would probably be the most likely avenue attempted first, and then only after that's failed would someone might consider surgical resection for that. And the prognosis of that is probably a little bit worse than someone who has a mesial temporal sclerosis. Certainly the surgical resection is much worse than that. I'm not sure that there is actually published data which talks about peel resections regarding those type of patients. And then I think you had asked about ones that are both focal and then ones that can generalize. And I think what we commonly see is where there is this thing called like hypersynchrony, where it starts out at one part of the brain and then then becomes diffuse throughout the whole brain. And that happens for many reasons. One is that we think there's a connection, and this is part of what we were talking about with where there's this propagation pattern which happens within the temporal lobe to have a seizure on the other side. And this happens either through the hippocampi or the anterior commissure, or there's connections within the different temporal lobes. And we see that there's a small seizure will start out just maybe within a millisecond, then it generalizes. So it starts out focal and then generalizes. And the prognosis of this would be, I would say, similar to someone who has focal seizures, where I think that if we can find that network of the seizure, or find the focal onset of that seizure, that perhaps we can provide some seizure freedom. Patients who have generalized epilepsy tend to do better on medication anyways, and again, we mentioned that in some forms of them there is this spontaneous resolution of them too. So I think certainly location without a doubt, affects the way that a patient would respond to therapy and also their prognosis.
Sure. Yeah, and we just yesterday got news of the FDA approval of deep brain stimulation as a third neuromodulation treatment for epilepsy. So that's exciting. I was just curious if you know whether that, it's FDA approved for focal epilepsies, but I'm curious if you think there may be a benefit of it for multifocal epilepsies or for generalized epilepsies.
Yeah, so right now, obviously at this point we can't recommend that, but so there's theories about generalized epilepsy and where those may occur from, and if they have some sort of, this is kind of debated too, by the way, but if there's like some sort of thalamic input in genetic generalized epilepsy, and so if we can if there's an ability to stimulate that, I think that will lead us to potentially some good results if we can do that. Yeah.
Okay, great. So many cases of epilepsy fall pretty clearly into a specific category or epilepsy syndrome, and this can obviously provide guidance regarding what to expect. It does seem, however, that there are a significant number of cases where the person's epilepsy doesn't fit into any category and is kind of truly one of a kind. How often do you see this in patients, and then how do you approach treatment in such cases?
Yeah, so I think I think although a lot of the epilepsy fits nicely within that, a single category, I think what I found having practiced medicine now is that most patients don't really fit within the book. In fact, most of them don't fit within the book of what a certain epilepsy form should be. And I think the first thing that we do when we see a patient who doesn't fit within that book is that we, of course, need to prove that they have seizures. And I think your question is already probably assuming that we have proven that they have epilepsy and figured out where it's coming from and how do we approach them. And I think what we do now, and again, this may change in the future, but what we do now is I think we try to find a medication which works best for that patient. And that includes both from a side effect profile and also if there's anything else we could treat with it. So if there's depression, might we add a medication which helps with that? Or if there's a patient has headaches, do we add a medication which helps with headaches? But really, I think it's more of this collaborative effort that the physician and the patient have in terms of refining the medical treatment for them. And the very unfortunate thing about epilepsy at this point right now is that medication and treatment is kind of a trial and error method, and having patients as we encompass this new endeavor with them is really important, because a lot of times we're using the data, we're using our past experiences to help us drive what we think might benefit a patient, but a lot of times we're not really certain as to which medication best works for them. I mean, there are certain epilepsies where we know that this medication is the go-to medication. Something like Absence, we have ethosuximide, but a lot of times we don't really have a clear medication which is beneficial for them.
Right. So that just
does that answer your question?
Yeah, that really emphasizes that the communication between the physician and the patient is so essential, so that you're meeting the patient's goals. And for one patient, seizures may not be the top priority. They may be more concerned about depression or cognitive function or side effects. So is that in those unique cases of epilepsy where there's not a clear guideline, it certainly makes sense that communication is essential. So,
yeah.
Okay, so we have just a few minutes left, and again, I want to emphasize that I will stay on past 1 o'clock to answer any questions. But in the 6 or so minutes that we have left, I do want to open it up for questions. For anyone that has them, so I'm just going to unmute all the lines just a second here. Okay, does someone have a question for Dr. Bunka?
Hi, this is Marissa Morgan. I have a question in regards to does asbestos cause epilepsy, or being exposed for a given period of time causes epileptic seizures?
Hi, thanks for your question. I'm not aware of asbestos causing that. I know that it obviously can cause lung issues, but I'm not aware of a specific circumstance of where it causes epilepsy. Now, I will tell you that my trick is that I don't say never, because when I do say that, I usually have to end up putting my foot in my mouth when I find out later that there is something. So that would have to be something that I would look into. Certainly it's not something that would be common, I would say for sure. But I guess I would never say never unless, I don't know.
Oh, okay, thank you.
Yeah.
Yeah, that is another thing that wasn't really mentioned is the idea of environmental toxins, and there are some examples of that of environmental toxins that could lead to epilepsy, right?
Yeah. So let me try to think. So there's trying to think of some off the top of my head that might cause it. I know that there are things that we induce, like mice models, to produce seizures, and so having, isoflurane or something like that, what could cause that. I'm trying to think of things that would
lead
like carbon monoxide, I guess, something like that.
I've heard that lead poisoning could potentially do that, but I haven't really wasn't sure of that. So
I haven't personally seen that yet, but I'll have to look into that.
Okay. All right, other questions? We've got a few more minutes left.
I'm Jenny, and I think it's possible that I get the complex partial, and they're unusual for me. And you physically might stop over time. So my seizures, whatever they are, they're caused by a tumor in the brain. They did surgery about 10, 11 years ago, and thank God it's sort of stopped, but I still get them. And I just wish it would stop over time. And the meds I take, you said there's risk factors, and what are some of those risk factors? And any suggestions on how I could stop the seizures, because I avoid caffeine, because I know that could cause it, at least in me. And I try to get enough sleep, which I don't always. And I try to be careful what I eat, and any other suggestions, and also the medical meds and the risk factor with the medication.
So just to narrow down your question a little bit, just because we're limited in time, if Dr. Bunka, maybe you could talk about someone who had surgery to remove a tumor, and whether possibly additional surgery might ever be warranted, based on the scar tissue that might be left.
Yeah. So I mentioned if we were to stratify a patient who has, so I know that you're not within the category of temporal lobe epilepsy, but people who have temporal lobe epilepsy and have resection, 30% of those will fail, and if they have a resection again, if they have found a new or maybe an expanded foci that they hadn't known was there, that there is a percentage of those patients within that 30% range that they have surgery that they will see seizure reduction with surgery. Now, your case, having been a tumor that was resected, is a little bit more complicated because the presumed etiology for your seizures at that time probably was the fact that you had the tumor, if you had them at that point. And then having had resection, and then now having seizures there's certainly, so there was, if we think about, again, you have an insult, so there's like some tissue now which is malformed in a way that's not supposed to be there. It's like a scar tissue kind of around that tumor, and that can certainly cause a seizure as well. So I guess there would be two questions that I would be thinking about when I were approaching a case like yours, and one would be is that did your seizure change after having had resection? So now there's a new foci and then a new symptom that's identifying the seizure. And if so or if not, then I would think about whether or not surgical resection might be something to consider for you. And the way that they would do that would be to do probably first would be to define your seizures through something like an epilepsy monitoring unit, but then after that would be to use likely some sort of intracranial monitoring to help further define where your seizure focus is occurring from. So, and I think that might be something I would be considering for you.
Okay, now I might not be able to get other surgery because the one tumor is on one side of the brain, another on the other side of the brain, which was too deep for them to do anything. But so it is something I could ask the doctor.
Yeah, and if there is potentially more than one seizure focus, a good option would be something like the responsive neurostimulator. The trade name is called NeuroPace, and there you're able to stimulate two different sites to help prevent seizure with that form of treatment. It's called NeuroPace.
NeuroPace?
Yep, kind of like a pacemaker, because it's a similar kind of thought process behind that as a pacemaker is.
Great, thank you.
Okay, well, Dr. Bunka, it is 1 o'clock, so I want to give you the opportunity to get off to your next engagement. And so thank you so much for a really, really detailed discussion of a very complex topic. So appreciate your time and all the information. And as I said, I will stay on the line for anyone else who has questions. And Dr. Bunka, if there's any very specific question that I'm not able to answer, would it be all right if I forwarded that to you by email or something?
Yeah.
Okay, great.
Yeah, of course.
Great.
Mm-hmm.
Well, thank you so
thank
much
you for your time. Thank you.
Yep. So any other questions or comments?
Do you know if I've as long as I can remember, I've sometimes suffered from depression, and I'm on medication for it, which has really helped. Mm-hmm. Do you know if that could sort of bring on a seizure? I know seizures can maybe cause it, but can it bring on a seizure? Wait a minute.
Well, certainly, yeah. So depression and epilepsy have a bidirectional relationship, meaning that having depression increases the risk of developing epilepsy, and vice versa. Having epilepsy increases the risk of developing depression. And that's because there are certain regions of the brain and structures and, aspects of brain chemistry that kind of overlap between the two conditions. So there is a definite association between those two conditions. And then specifically asking about whether depression can trigger a seizure, yes. The short answer is yes, because one of the key symptoms of depression is stress. And stress, as we all know, is a common trigger for seizures. So if you're suffering from depression and it's not well treated, then you're going to have more stress. Depression can also interfere with sleep. That's a very common thing. So if you're not sleeping well because of your depression, then that can further reduce or increase the risk of seizures. So either both directly and indirectly, depression can make it more likely for you to have seizures.
Wow, thanks.
So it's a good thing you're getting it treated. Other questions?
Russ?
Yeah.
Russ?
Yes.
I just want to let Jenny know, I think it was Jenny, my son Ian wears a NeuroPace because he has multiple points where the seizures originate, and it has helped somewhat, but with the medication. I mean, he's not completely seizure free, but it's been a help.
Yeah, thank
wow,
you
that's
for
good
sharing
to know.
that.
Thank you.
And that is the case with, both vagus nerve stimulation and responsive neurostimulation. It's rare that people become seizure-free with those treatments, but people do often see pretty significant improvements. And like I said, they're often, in most cases, medication is still used, but there are some cases where if you do get enough improvement and you're on, let's say, 3 or 4 medications, you might be able to, reduce that down to 1 or 2. So yeah, multiple benefits of those treatment options, and definitely for someone who may have more than one seizure focus, the responsive neurostimulation or NeuroPace might be helpful. So, thanks.
Thank you.
Other questions or comments? Okay, I guess we will wrap it up then. So thank you everyone for participating. I do want to remind you, if you do have any further questions or you want to learn more about these and other topics, you can visit our website at epilepsymichigan.org, and you can always call us at 1-800-377-6226. And this call will be added to our website, the recording of the call, so you can listen to this again if you missed anything. The next Learn and Share conference call is on June 6th from 6 o'clock to 7:30 p.m. The topic is transition planning, consideration for teens with epilepsy, and we have multiple panelists involved in that, so it should be a great discussion. So thanks, everyone.